I'd like to welcome each and every one of you to our 2016 Spring MSREI dinner conference. And it's so nice to see everyone here tonight and having an enjoyable time, great company, great food, great folks who've helped us to put this together, great support. So I'm really happy that you're all here. I want to give a warm introduction for our guest tonight, who's going to speak and enlighten us. And what's really cool about Dr. Kutteh, Billy, if I may say, and I've shared this with a few people, he's not here to teach us what he knows. He's here to share with us what he's learning. And that's our mission here this evening, along with good food and camaraderie, is learning. And I've just found him to be one of the most humble, easygoing, gentle, yet has high regard for best quality of what we do. And Billy is someone who I've always reached out to with emails and otherwise for advice. This is it was 10 years ago that Billy spoke to our group, and we're really glad to have him back. Dr. Kutteh, and I'm going to just give a little background for those who may not have had the privilege to get to know him. He's clinical professor of reproductive endocrinology and fertility in the Department of OBGYN at Vanderbilt University Medical Center, and he's professor of the Department of OBGYN of the Fertility Preservation Clinic at St. Jude Children's Hospital in the area of oncofertility. And he has, with all the things that he does, he has a very busy clinical practice. And I really admire how he juggles all those things. In addition, he's running a high technology immunologic laboratory, and that he will discuss some of his experiences over his career with that. And he also directs the Recurrent Pregnancy Loss Center, evaluating couples with conditions and referral base from really all over the United States. He received his PhD from the University of Alabama in molecular cell biology, one of those just basic Cush classes you can do online. That's what he told me. I believe everything he says. Well, that speaks volumes. I think we just had a fax machine then. But he did his fellowship and also had a faculty appointment in REI at the University of Texas Southwestern Medical Center in Dallas. And that's really where the flames flared and the fire took off to really follow up patients in this area of recurrent pregnancy loss, and where a lot of great work was done that serves as a foundation for what we do in our everyday practice, as Billy has shared that with everyone. Overall, he has been around the globe sharing what he's learned with people. He's published over 350 articles, different textbooks, yada, yada, yada. It's just a matter of it's contagious, what he has to do and say. And I think that with that, I really want to turn the podium, or as he will pace in front of us to share with us, Dr. Billy Kutteh.
Okay, thank you. Can I turn this thing a little bit? Yeah, I think things on. Thank you very much for that introduction.
Sure. Oh, one thing.
Where are you going to sit?
I'm going to sit over here.
Okay.
But I just want to not steer your slides. Remote will work with you.
I didn't realize it was 10 years ago that I came up. Was it this same group that
Yes.
I talked with? Okay. What do I want to say? I just came up this afternoon, actually toured Michael's new office. I don't know if everybody's seen it, but it's envious with the technology. It is. I mean, it is. The technology and everything, and how you've really used your knowledge about the lab and how to set up an office for patient care and patient comfort. It's actually incredible. What I want to try to do, and I know we've got a mixed crowd. We've got embryologists, we got some nurses here. Do we have like office staff? I don't know who's what here. Who's physicians? Let me see. Hands, and then nurses, and then lab folks. Okay, so I thought it was going to be like one table. I thought it was going to be Michael's office, and then I talked to him for about an hour the other day, and he said, "Oh no, it's going to be more people." So I'll try to present it so everybody's going to get something out of it. For the lab folks, I'm a HCLD. I was director of our lab for 20 years. I know how to do ICSI. I've done all that stuff. I don't do it on patients, but I have done it. So I'm pretty familiar with lab troubleshooting. And this area of pregnancy loss, to me, particularly with IVF, is an interesting one that in some centers is a battle between physicians and lab. There's a lot of things in the lab that we know influences the loss rate from IVF and other treatments, and there's also things about the patients. So anyway, I'm very familiar with all those things. Objectives are just to discuss the trends that are going on with pregnancy loss. And Michael wanted me to talk about a couple specific things, so I've added those in, PGD a little bit, and thyroid antibodies, some of the things that are more controversial. I'm going to talk about those. So when I was in Dallas, I did my fellowship there, and Dallas, for those of you that don't know, they have the largest numbers of deliveries under one roof of any obstetrical hospital in the country. I think now it's like 22,000 deliveries per year. I think they have 18 residents or 20 residents per year. It's a powerhouse. They write the textbook of Williams obstetrics, and so I'm giving you this background, but the reproductive endocrinologists are like the black sheep of the OBGYN department. We had the smallest offices, we had the worst labs, we had the furthest away from everything. And when I went there, I was already a PhD in molecular biology and immunology, and I didn't know what I was going to do. And I got there, and there was this area of antiphospholipid antibodies, so I'm technically an immunologist. And I was interested in it, but I had to dutifully go around to each of the 8 MFM faculty members because all the patients with pregnancy loss were sent to MFM at that time. And I went through, I don't know how many, maybe 1,000 charts, and they would send them to the geneticist, and the geneticist would draw out the little thing with the X's and the O's, and the mother had diabetes and this, that, and the other. And then they would tell them, well, it could be this, it could be your uterus, it could be immune things, it could be, and they would order chromosomes on the parents, and that was it. And then there'd be a letter that went back out to the doctor. So one of the things I did with the massive numbers, back then they were doing about 15,000 deliveries a year. And so I amassed 5 years of data. This is an unreferred population. And so right now, I don't know what reality is. About 30% or 40% of my patients have recurrent pregnancy loss. That's not the reality of the world, but that's what I see. In Dallas, it was an unreferred population, and it was about 1/3 Hispanic, 1/3 African American, and 1/3 Caucasian. And we had a computer system where we could punch in diagnoses, and we knew how many deliveries there were. And at that point, I estimated that 1.3% of the patients that were coming to our clinics in Dallas had recurrent pregnancy loss. At that time, 3 or more losses. That's a minimal estimate because those of you who went through residency know, I mean, people couldn't come there because they didn't have a car, they didn't have bus money, they couldn't get there. So this is a lower estimate of the problem. And the real problem is probably about 3 to 5% of all patients. But that was a minimal estimate that I did back then. And we all know that as women get older, the miscarriage rate goes up and the pregnancy rate goes down. You don't have to be doing IVF to know that. You know that that's the case. And we also know that now, due to genetic testing, that if you look at the maternal age and you look at the aneuploidy rate in the oocytes is probably the most important predictor of miscarriage. So these are all just basic things that we know about, but it influences what you tell a patient when you see them in your office, whether she's 30 or whether she's 45, whatever age she is, as far as what's going to be her risk of having another miscarriage. Now, there was a pointer thing here. No. This is just a theoretical calculation, and it goes to address the recent ASRM guidelines like 3 years ago. They changed the acceptable definition of recurrent pregnancy loss from having 3 consecutive losses to 2. And this was just a theoretical calculation that some authors made, Leslie Reagan, who's in Europe, in her group, to show you the impact of changing that definition as how it's going to influence the patients that you see. So if you use a definition of 2 losses, about 1 in 45 patients that you see are going to meet that criteria. If you use 3 losses, 1 in 300, and some clinics in Denmark use 4 and 5 losses, where their state health plan is paying for certain tests and treatments. So by changing that definition, it changes the character of the patient that we see and what the problems might be. It used to be easy when I was a resident. Williams' textbook, again written in Dallas, just said 3 or more spontaneous pregnancy losses. I don't know what would happen if they had this in there now with all this equal rights and bathrooms and all that mess. But, you know, fathered by the same partner, 3 losses in a row, right? That was easy. 3 losses, consecutive, no discussion. So, without the nice database system that you have now, we still have paper charts. We went through about 2,000 patient charts, and we published this paper in 2010. And basically, I wanted to ask one question because I always thought it was wrong. You know, we would see a patient, and according to ACOG, which has withdrawn their statement, and ASRM, the patient was supposed to have 3 losses before we as physicians got concerned about their miscarriages. And I said, nah, I never thought that looked right. So at least in my practice, before any guidelines were changed, if the patient was a little bit older and they'd had 2 losses or they were very concerned, we would usually start doing a workup. And so there was one question that I wanted to answer with this study. There were a lot of questions that could be answered, but what I wanted to know was, did the number of losses affect the frequency of abnormal findings? If we did a workup with 2 losses or 3 or 4 or whatever, what was the difference? And so this was a result of some of that data. Patients with 2 losses, 3 losses, 4 more losses. I showed you the list of evidence-based tests, and those are things that everybody would agree on. Karyotypes, check the uterus, check the thyroid level, check antiphospholipid antibodies, and there are other tests that we classify as investigative. But the point is, it didn't matter whether a patient had 2 or 3 or 4 losses. The frequency of abnormal findings was about the same. And even on the investigative tests. So best case scenario, if we did all the tests that people were talking about back then, we could find about 60% of the patients, we'd find some problem that maybe was the cause of them having their pregnancy loss. But it clearly told us you don't have to wait until 3 losses to start doing these tests. And it was very satisfying to us a couple years later when ASRM changed this guideline and referenced our paper as one of the key papers, that they said you can consider doing evaluation after 2 losses. And I think now most places are at least talking to the patient and offering that. So that was an important, I think, first step that came out of the work that we did. I can tell you that the insurance companies figured it out long before ASRM did. When I was in Dallas, this must have been 1996, 1995, I had the director of one of the insurance companies call me to refer me a patient. I said, this is unusual. I've never had the insurance company call me to refer a patient. You can't see, I'm in your way. And I said, why are you doing this? And the medical director said, we figured out what it costs for a lady to have a miscarriage. We figured out the number of office visits, the number of blood tests, the number of ultrasounds, the DNC, the surgery center, the anesthesia, and we figured out the cost of doing a workup for pregnancy loss, including karyotypes and evaluating the uterus and a couple hormone tests and a couple immune tests. And they said it's far cheaper to do the workup, and if you find half the people have a problem and can fix it, we save money. They figured this out 20 years ago, okay? Way before our groups and societies figured it out. So I don't know what it is in this market, but in our market, we never have a problem getting these tests paid for by insurance companies. This is another interesting thing. In that same Williams book that I quoted when I went there, they didn't do anything else except genetics for recurrent pregnancy loss. And when I went around and asked them, they said nothing else is proven. Well, genetic problems are only 3 to 5%. And they said it's just bad luck, these women that have a miscarriage and another one and another one. This is an excellent calculation that shows what's the chance of somebody having a miscarriage just by chance. They're just unlucky. And it's based by age. And you can see in the young woman to have 3 miscarriages or even 2, it's pretty low. As you get older, the frequency is higher. But what it says is the chance of this happening just at random without some cause that maybe can be determined is not very high. It's actually pretty low. So to just push off a patient and say, oh, just go away and try again and everything's fine, don't worry about it, it's not really an appropriate response. So 2 losses, big point. Well, it got confused because what do we consider to be a pregnancy loss? That's the next question. What do we consider to be a miscarriage? And again, back in my training days, it was easy, very easy. Miscarriage was a loss of a pregnancy at 20 weeks, before 20 weeks. Okay, that was it. No details, no footnotes, no nothing. Well, we've got all these kinds of losses now in different terms. Pregnancy of unknown location, maybe it's an ectopic. We never saw anything in the uterus, or early embryonic, or even biochemical before that. And all the way down to categorize what a miscarriage is. Well, I know what my patients say. My patients say they got a positive home test, or even they're late on a period and their breasts are tender, and they saw a fuzzy line. They say, I had a pregnancy, and if it doesn't turn out to a baby, they say it was a miscarriage. But ASRM is piped in, I think introduced a little bit of confusion. ASRM said pregnancy is defined as a clinical pregnancy that's documented by ultrasound, so it's got to be at least 5 weeks, 5.5 weeks maybe, or histopathological examination, meaning the patients either have to have a DNC or had to have passed something that we evaluated and sent off to pathology. Well, there are a lot of patients in our practices that don't meet either one of these criteria that clearly had positive pregnancy tests, but they don't count according to this definition, right? So what have we used in our studies? In our studies and the data that I present in our studies, we use this definition. A pregnancy is documented by an appropriately rising quantitative HCG that fails, and using data from Kurt Barnhart, who's done a lot of work on ectopics and pregnancies of unknown location, less than 7% of those pregnancies will be misclassified. They could have been ectopics that we'd never know. So there are in all these data 7% that could have been ectopics that were classified as a miscarriage, and we'll never know that. Okay, so how many losses we know, what counts as a loss, we've got different opinions, and what are we supposed to do? So we found the patient, she's got miscarriages, she's sitting in our office, what are we supposed to do? Don't ask ACOG, they don't know. They had this statement they wrote in 2001, it was withdrawn and nothing has been issued. Years, I don't know how many years it's been, 5, 6, 7 years. They have no official statement on pregnancy loss and what we should be doing. Nothing. They're working on it. ASRM issued this just a couple years back, karyotypes on both partners, evaluate the uterine cavity, some hormonal tests. Some of this is unreferenced. We do get a hemoglobin A1C, but they say get it, and there's no references in their bulletin. Go back and read it. Evaluate for PCOS, lupus anticoagulant, anticardiolipin, beta-2-glycan, no inherited thrombophilia. So this is what ACOG says we should be doing. I mean, ASRM says we should be doing. So this is what we call in our office the standard workup that we would get on any patient that we classify with recurrent pregnancy loss. Now, going back to our paper, what did we find? And this is just a little bit more detail. This is our control population of women who'd had previous pregnancies, no miscarriages. And these are the different things that were considered standard workup at that time. Genetics, check the uterus, immune test, thyroid, factor V. I think that's the reference down there. And again, it's broken down into 2, 3, 4 losses. This p-value is comparing 2, 3, or 4. It's not comparing it to the control. In every case, the findings were positive compared to the control. And so these were the evidence-based tests on the women. And we really couldn't see any trends, you know, as they had more losses about any of these factors. Again, reinforcing the fact that 2 losses probably was an adequate number to make the diagnosis. So genetics, some people don't do genetics, particularly now with all this genetics we're going to talk about on the miscarriage or products of conception. This is an expensive test. It's the G-banding. I don't know, where's our genetics? So she's gone. The G-banding, I think it's 500 bands. I'm not sure exactly what we can do with G-banding now. But what we're looking for is a balanced translocation in one of the parents. A balanced translocation like this one I've illustrated, chromosomes 4 to 18. In the parent, thankfully, a piece of chromosome 18 jumped over here to 4, but the piece of 4 jumped over 18, so the parent's fine. But when they reproduce, they may give one chromosome that's missing a hunk of the DNA, and the baby comes out unbalanced, and that's going to be a miscarriage. The importance of that is that you can give the patient some information about their future outcome. So if somebody's got a reciprocal translocation, you can tell them they're going to 50 to 70% of the time they're going to have a miscarriage in the future. And these are plenty of studies that back all these numbers up. Now, this is my one slide on preimplantation genetic testing, I think. So many reproductive endocrinologists, particularly back when things got tough, patients' volume went down, embryologists were getting laid off, some doctors were getting laid off, and we needed more patients to run through the factory. We needed more patients. And so many clinics, I can't tell you how many I know of, started running these patients through pregnancy loss. Well, they're coming to our office. We've got all the factory over here to do IVF. We got the gas lines hooked up, right? Let's get them through. I can't tell you how many charts I've gone through, and this is what people did. They didn't check anything else. And people would come and ask me for a second opinion. I say, well, okay, it's okay to do that, but first you got to find out why you're losing them. You can spend 10, 12, whatever it costs to do IVF up here, and you still can have a miscarriage. So you got to find out why you're having a miscarriage. But the Canadian equivalent of ACOG, last year, they met and they said, we think it's reasonable to do IVF with PGD diagnosis, looking for balanced translocations in patients with recurrent miscarriage where one of the parents has a translocation. Now, genetics also, we can look at the genetics on the miscarriage, what happened there. And this is, I think, kind of a new trend in the way that we're thinking. But the karyotype or the genetics on the miscarriage or the products of conception, or miscarriage tissue, I think is the new appropriate term, can help you predict what's going to happen in the future. So, for example, if the first miscarriage, a karyotype was done on the miscarriage and it was normal, on the second miscarriage, about a third of them will be abnormal. If it was abnormal on the first one, about 2/3 will be abnormal. What that's saying is if it was abnormal the first time, there's a greater chance it's going to be abnormal the second time. If it was normal the first time, there's a greater chance it's going to be normal the second time. And all right, let me go back. This is going to be a question before I show you the answer. I got 2 groups of patients. One group is a recurrent pregnancy loss population, and we do genetic tests on the miscarriage. The other group is the couple that just got pregnant and had a miscarriage. Let's say their first sporadic, just spontaneous miscarriage. They don't have a bunch, they just have one. We have unlimited resources, and we have done genetic tests on the miscarriages to find out which ones are normal genetically and which ones are abnormal. Which group of patients The patients who've had a bunch of miscarriages or the patients who've had just their first sad miscarriage? Which group of patients, when you do genetic tests on a baby, is going to have a higher rate of genetically abnormal losses? Everybody got the question? This group with a bunch of miscarriages, or this group over here who just had their first miscarriage? This one?
First loss.
This one? Good. This is a very bright crowd. It's exactly right. By age group, the women who have a spontaneous miscarriage, a greater percentage of the products of conception are going to be genetically abnormal, and it's at all age groups. Now, what this says to me is there's something else. There's definitely genetic problems going on, but there's something else going on. There's something else going on. It's not all genetics. Joe Lee Simpson and I were on a program together once, and he said 90% of miscarriages are due to genetics. We just don't know how to look for the genetic problem just yet. And I said, well, maybe. And I tried to, it was fun. I kind of debate with him a little bit. But it's the one that had the spontaneous miscarriage. And there's been a couple groups. Now, what do we see when we do standard banding on the miscarriage? This is the frequency of problems. We've all seen, trisomy 16, 22, 21. Let me see if I've still got, yeah. This accounts for like 60%, just these 4 chromosomal abnormalities in the miscarriage. And all these others down here, some of the bigger chromosomes, chromosome 1, chromosome 3, for those of y'all that don't know, the bigger chromosomes were found first. We call them number 1, and then as they go down, we get to 21, the chromosomes get smaller. Those were numbered last. Well, we don't see as many problems in when we do banding, G-banding chromosome technology on miscarriages. But when we do PGS on women, I do have another slide on PGS. when we do PGS on miscarriages from couples who've had 2 or more pregnancy losses, we get this very interesting pie chart, which is courtesy of Paul Brzezina, our new partner, and Bill Kearns. What we see is that every chromosome is almost equally represented in abnormalities. This is using 23 chromosome microarray, and these are on some early pregnancy losses. So the difference is X and Y were 3.1, and that was the lowest, and the highest was 5.8. So that means that there is aneuploidy with every chromosome in these women. We don't see them all. We see the 16, the 18, the 21, 22. And I think these others are what we have as biochemical losses. You got a problem with chromosome number 1, that's a lot of DNA that's messed up. And there's not enough information there for that baby to grow at all. So this is a lady, you get the HCG of 80, and then it goes to 110, and then it goes to 90, and then she starts bleeding and calls you up. I think. I don't know. I don't know how to test for it. But I think that's what's going on. Because we know in their embryos, we see just about everything represented. Now, I think for a moment that's it for genetics. Anatomical problems, what do y'all do? Sonohistograms, you got that nice hysteroscopy thing in your office, right? We love to do sonohistograms. We do them in our office. We think it's great. Patients like it. We find a lot of problems. I still like to operate, so we get some nice surgical cases out of it. We train our nurses to do it, so it's fun. It's good. And these are the different problems that we find, congenital problems with the uterus. These are some of our sonohistogram pictures that we find problems with. And so you got to look in the uterus. I was given a program like this down in Florida a couple of years ago, and somebody was asking me a question. I've got a patient, she's got miscarriages, and wanted to know what I would do. And I said, tell me what you've done. Well, I didn't do genetics because they're expensive and it's very low pickup. I said, okay, well, did you check her uterus? No, this is the only partner she's ever had, and we didn't check but by the time we'd gone through, all they'd done was like a thrombophilia panel, which we're not even supposed to do anymore. And I said, well, I don't know what to do with that patient because that's not how I think you should be treating your patients. But I said, it's like if you got a kid and they got an ear infection, right? If you take them to the pediatrician, what do you expect them to do? Look in their ear, right? Look in their ear. So you got to look at the uterus. I mean, you don't have to go to med school and 3 years of fellowship to know this. But people don't do this stuff. It's just amazing. We got another set of data together. We wanted to know, what do we find, and does it matter if you have primary recurrent miscarriage, which means you never had a kid, or does it matter if you've had secondary? That means you had a kid and then you had a bunch of miscarriages. Does it matter on primary versus secondary as to what we find wrong with the uterus? And for everything except one, it didn't matter. We did the overall analysis and there was a difference between primary and secondary. And then we did congenital anomalies, and that's where it was. It wasn't acquired things, fibroids, adhesions, polyps. Septate uterus found twice as frequently in women with primary recurrent pregnancy loss as secondary. And that kind of makes sense. These women, there's no good place for the embryo to attach, and they lose it, so we go in there and snip it out. So this thing we published, I don't know, like 2 years ago, 2003. Largest study that anybody did. Now, if I had that system like you, I could have punched a few buttons and got this. But I had to get college students and residents, and we went through the charts. Painful. Autoimmune, this is, my area of interest. Autoimmune lupus anticoagulant is actually an antiphospholipid antibody. We test for it in a different way. Anticardiolipin and also antiphosphatidylserine antibodies. I don't have it on this slide. We see in a lot of these patients. We've gone through a thing of doing a bunch of panel of antibodies and an argument, should we do these panels or should we not do these panels? What is this right here? Diphosphatidylglycerol. Does anybody know what this is? Is what? No. This is cardiolipin. So all these other things that people argue about, cardiolipin is actually an inner cell membrane. So by the time somebody develops antibodies to cardiolipin, cells have died. These other phospholipids, particularly phosphatidylserine, is an outer membrane antibody. And all cells in the body have phospholipids. So when the next paper comes out in Fertility and Sterility and they say, we found antiphosphatidyl whatever on endometrial cells, so what? They're on every cell in the body, in the lipid bilayer. So right now, we test everybody for phosphatidylserine. Most major labs do, LabCorp, Quest, everybody we use, lupus anticoagulant and antiphospholipid antibodies. And we all tell our patients what? These cause blood clots, right? Because we treat it with heparin or Lovenox. Causes blood clots. Well, they can cause blood clots, but what do we think is going on? This was one of the problems when I was starting out, is a lot of the studies that were done, they didn't start enrolling patients for treatment trials until they were 8 weeks pregnant with a heartbeat. Now, how many of your patients have already lost the pregnancy by then? Tons of them. So by the time you've weeded out all those people, you could do anything to them. Give them vitamin D, right? That's the important thing now. More vitamin D. Everybody's vitamin D deficient. And they would do wonderfully. Well, the problem is what happens before. And I remember presenting this, and Jim Scott, who at the time was the editor of the Green Journal, I was presenting at ACOG about early pregnancy loss and antiphospholipid syndrome, which he, by the way, had written tons of papers on in their whole group. And most of my patients were before 10 weeks. And I was presenting, and he said the first question, he said, well, Billy, he said, these women don't have real antiphospholipid syndrome. So thank God I had a paper of his that I had memorized. And said, well, this is how you defined it. 3 losses in a row, same partner, antibody levels had to be at this, twice 6 weeks apart, now it's 12 weeks apart. Anyway, they met the criteria. So we finally got that paper published. But the important thing to know is this happens way before the blood vessels are formed. Heparin, or Lovenox, we still prefer heparin, is not just working as a blood thinner, as an anticoagulant. And this study is one of the greatest studies, I think, that shows that. So if you take placental cells and you put them in culture, they will fuse together. Guess what they fuse with? Phospholipids melt in the lipid bilayer. And in the placenta, we have things called giant syncytia trophoblasts. And the incredible thing about these cells, they're multinucleated, and they can do all kinds of things. They can form as endocrine organs, they can form as like a liver, a pump, they can produce hormones, they do all these wonderful things, and then what happens to the placenta? It gets chunked. But this is the only organ in the body that can do this, the placenta. They fuse, they become these giant multinucleated cells, and they do all these wonderful things. What happens in the dish, in the culture dish, if you dump in blood or purified antibodies to this system, you dump in antiphospholipid antibodies, anticardiolipin, the cells no longer fuse together. They don't form giant syncytia trophoblasts. They don't produce HCG, something we can easily measure. If you dump heparin in the dish, there's no blood vessels here. If you dump heparin in the dish, they do this. They go back to doing this. Okay? So this is happening at the placenta very early, and there are a lot of papers now that say inflammation and complement activation and a bunch of things. But it's easy to say it's a blood thinner, but it's stuff that's going on very early at the placenta. So what does everybody say? The combination of twice daily unfractionated heparin or low molecular weight heparin and low dose aspirin appears to confer significant benefit. But the efficacy of low molecular weight heparin, which we've almost universally jumped to, has not been proven. So we still, in probably 80% of our patients, use twice daily low molecular weight prophylactic heparin in these patients. The other immune thing that I'm going to touch on is thyroid antibodies, antithyroid antibodies. So the first point is that in our patients, even though the lab slip says 0.5 to 4.5 is normal, we want it to be, and it depends on the ASRM, change the number, but we want it to be between 1 and 2.5. And guess who said this? In 2007, the American Endocrinology Society, or whatever the equivalent ASR, this is not new, this is old stuff. It's been around for a long time. It just takes a long time for people to change in medicine. ASRM issued a statement last year and they said 1.0 to 4, no reference for that number, but okay, 4 instead of 5 or whatever. Thyroid antibodies may show up before somebody's antithyroid. So something happens, a virus maybe, antibody forms, it cross-reacts, it attacks the thyroid. The thyroid's still working, and it may be months to years before the thyroid decreases in its function. So if somebody has been tested for antithyroid antibodies, they're probably going to develop thyroid disease somewhere down the road. 15 to 20% of reproductive age women will have antithyroid antibodies. So if you want to have something to talk to your patient that you found, this would be a good test maybe to run. Nobody says do it just yet. The levels of thyroid hormone that are considered normal vary based on where you are in pregnancy, and that's kind of a graph, what happens to TSH, and its HCG influences this as it goes up and then comes back down. Way back in 1999, we published a paper with Richard Scott and another one with Schoolcraft. And we said, we found increased antithyroid antibodies in women who had recurrent pregnancy loss, and we got a bunch of their samples from patients undergoing IVF, but we didn't see it in patients undergoing IVF, and we said, this might be something that we want to look into. This, like 18 years ago. We just found them. We didn't say treat them, we didn't say what to do. We just said they're there. This is something that's different in these patients. And now, more recently, British Medical Journal, thyroid antibodies are associated with miscarriage and preterm birth, strongly associated with miscarriage. And in this is a forest plot, meta-analysis, a bunch of studies lumped together. And if the bar goes to the right, whatever you're looking at is found more frequently in those people. So in this case, anti-thyroid antibodies. If the bar goes to the left, less frequently. If it's right on 1 or it crosses 1, it's not considered as significant. I don't remember what our study showed. We were just, tight means big number of patients. We had like 900 patients. It didn't cross 1, so we concluded it was significantly higher. And now all this meta-analysis is just about right on our bar 15 years later. And they concluded. They also looked at women with infertility, and same kind of finding, but it's not fully significant because it crosses that 1 axis. And an older paper saying, hey, if you've got any thyroid antibodies, but your euthyroid, your TSH is normal, maybe these women will benefit from low doses of levothyroxine. This is 10 years old. This isn't something new. It's just kind of been stirred up again. So here's the statement from ASRM. There's good evidence that thyroid autoimmunity is associated with miscarriage and fair evidence that is associated with infertility. Levothyroxine may improve pregnancy outcome in women with positive thyroid antibodies. Has anybody read this thing? Yeah. Okay. Do they recommend testing for anti-thyroid antibodies? No. So I don't know how you're going to find it. They don't recommend testing, but if you got them, it might cause a problem. So anyway, again, none of this stuff's crystal clear. So they're trying to make a statement that protects us all in a way if we're not testing for this. And they're not telling us that we have to, but they're saying there may be something there. Okay, so this is what we and 2 or 3 other groups have proposed. This is untested. This is not ASRM guidelines. This is not ACOG guidelines. This is just, we're trying to think. And what we think is, and we're actually testing this, I've got a student from Rhodes College who's going through all my charts to see if this is correct, and it may not be. But first miscarriage, we don't necessarily do anything unless your sonographer tells you, oh, it looked like she had a big old septum, or you're doing your prenatal screen and she had a positive RPR, and you check the treponema antibodies and they come back, they're negative, and it was a false positive test. That's a sign that it might be cardiolipin antibodies. But in the usual case, you don't do anything if they've had 1 miscarriage. On their second miscarriage, and this message really has to get out to the OBGYNs because we don't see them. On their second miscarriage, send the miscarriage for 23 chromosome microarray or banding karyotypes or whatever you can do. And based on that, then decide what to do. If it's aneuploid, if it's abnormal, trisomy 22, okay, we know what happened. Something was wrong. Thank God the woman's body picked up on it and she lost the pregnancy. It doesn't mean her body failed, it means her body worked. We stop. If it's unbalanced, well, that means one of the parents has got what? Balanced translocation. Unless it occurred de novo, that could happen, but usually doesn't. Check the karyotypes on the parents. And I would say now, based on the ambiguous ASRM guidelines and the clear Canadian Society of OBGYN guidelines, that person probably should be talked to about PGD if they want to. Or they can go ahead and you can give them the odds. If it's normal and you have ruled out maternal cell contamination, 46XX, and you've done a 23 chromosome microarray and they've told you it's not the mom, then these people need to get a workup. They need the whole spiel that we've been talking about. This has been suggested by 3 different groups. Nobody's tested it. So we're actually testing this model now retrospectively on women who had genetic testing done on their miscarriage, and we're saying, what if we had that genetic test and we stopped right here? How many septum would we have missed? How many antiphospholipid antibodies? How many other things would we have missed? And it looks like we hadn't gone through that many charts. It looks like about 20% of the people would have missed something. And all that says is you can still have an aneuploid miscarriage and have something else going on. Doesn't mean that it's impossible for something else to happen. And so what is the workup that we're doing? We're checking the uterus, sonohistogram, HSG. We're checking hormonal. We have done, and we've got a presentation at ESHRE in July on mycoplasma and ureaplasma and how often we find it and what's the outcome there. Autoimmune factors we've talked about. I didn't mention lifestyle. 2 or 3 years ago, ESHRE people emailed me and said, Dr. Kutteh, we're having a pregnancy loss symposium. We want you to come and talk. And I said, fine. Where is it? They said, London, and we'll pay for your flight and all this. And I said, good. I said, what do you want me to talk on? And they said, we want you to talk on caffeine, tobacco, alcohol, and obesity and effect on miscarriage. And I said back to them, I said, well, you know, I talk on phospholipids or other stuff, but I said, I've never given that talk. And they said, we're going to pay your hotel, we're going to pay your airfare, we're going to pay for your food for 5 days. And I told them I'll figure it out. And then genetics. Get genetics on the parents or the products of conception if they hadn't had it done. And you can go back now and get it on the paraffin blocks, actually. So if you got somebody in your office and you want to go back and look, you can get the paraffin blocks. It takes a little bit longer, and you can send it off, and I think it's valid. Yes, valid. This same group that did a lot of predictive models had proposed that maybe these women with recurrent pregnancy loss who are unexplained, this is the thing we don't know what to do with, we should divide into different groups. The older patient they called type 1, biochemical losses, they're more genetic problems, anybody who's older. Type 2, you know, we still don't have an answer. We've done all the tests. We don't know what's going on. There's something we don't know about out there yet. And they just said maybe this would help you decide who needs genetic, you know, testing and who doesn't. And it's not proven. They're just saying, hey, this is another way to think about it. This is a great study from Ole Christensen's group in Aarhus, Denmark. And there's 2 strengths of it. Large group. In Denmark, the government pays for pregnancy loss evaluations, but there's only 2 or 3 clinics. In a small country, everybody has to go to these clinics. And this is just looking at what happened to our patients. They came in, time 0 is when the patient came to the clinic, whether they had 3 losses or 6 losses. That's time 0. And they did everything that they thought was appropriate at that time. And you can see over this time for follow-up, a lot of things changed. The factor V Leiden and HLA testing and different things. But whatever was deemed appropriate at that time, they were doing everything that was reasonable to help these patients and treating them. And this is the outcome. And I keep a copy of this and the next slide in my drawer in my consult room, and I show it to patients on the very first visit, because people think that we're going to do something and they're going to be up here, whether it's IVF or whether it's treating them surgery. They think we're going to fix this 100%. They don't know that it's not 100% for anybody. Not for my wife, not for my daughter, not for your daughter. You don't have a daughter? You have a daughter. You do. Not for anybody. So I say, okay, well, how many miscarriages have you had? And here's, you know, by 2 years, 60% of the people, us doing everything that we know, not including IVF and preimplantation genetic testing in this thing, they got a baby at home. And it kind of caps out at, you know, 70-something%. This is a great study as a control for people who advocate genetic testing. This is the bar you have to reach, because this is what it is with tender loving care or whatever you want to call it in your office. Of course, if she's older, I mean, if she's got more miscarriages, they have a poorer prognosis, but it's still not bad. And then same thing with age, time 0, years of follow-up. Here's the younger woman. I mean, it's over 80%. So there's a difference in a 24-year-old with 3 miscarriages and a 44-year-old with 3 miscarriages in what their prognosis is going to be no matter what you do. So these are the bars that have to be reached with whatever it is that somebody comes and convinces you that you need to do, whether it's IVF with PGS or it's natural killer cells, which I didn't talk about, or whatever the next thing is that somebody's going to talk about next week. It's got to be this in that age group, I think. So I'm done. Right?
Thank you very much.
Thank you.